I think the right time is the designing phase. I mean, that's where I feel all your expertise have to come on table. People are savvy for technology, we are savvy for using new inventions. We are also trying to move away from the conventional way of systems. Now we have such a beautiful material like your boards which we are using. So those have become very competitive over the time. We are doing one APMC market in Latur. There the whole concept is that we are putting all the prefab structures all together as a 7 lakh square feet of development. So it's supposed to be complete in 4 months' time. We were able to reduce 30 mm sizes to 19 mm sizes. We were able to reduce the structural costings of the facade. So there are so much of advantages of using the new things.
Topic 1, Precision Medicine, which will be presented by Ms. Anu Acharya, CEO, Map My Genome. Topic 2, Evidence-Based Treatment, which will be presented by Mr. Akansh Khurana, co-founder, Technology Healthcare Big Data. The last session would be presented by Mr. Akhil Ganatra, Managing Director, Clancy Global, on the topic of Infra Tech. I would now request Ms. Anu Acharya to begin the session.
So hello everyone, I'm Anu Acharya, I'm the founder and CEO of Map My Genome. And today I'm going to talk a little bit about precision medicine and how genomics can help solve some of the COVID challenges that we are currently seeing. So the topics that I will cover very briefly is that there are many things that are there involved in the science for COVID-19, a little options of how genomics is helping in the testing, and then talk a little bit about genomics for prevention. That is one of the products that we've been working on the immunity aspects. And then how does sequencing help us in coming up with new drug targets and also vaccines, as well as finding out other information about the disease itself. So I will, since it's a short presentation, I will skip through a few of the details, but I will go through this right now. Now, as most of us know, this virus is a RNA virus, and it is it basically is a protein in a lipid membrane, and it comes into our body using the ACE2 receptor, using the S protein, and it helps. It basically hijacks the cell machinery to make copies of itself, and these virus particles then look to infect all over other cells to infect, and therefore the disease spreads. Now, how does genomics really help us in this is an aspect that we want to consider. Now, after we have been infected, there are also aspects that we will look for, which would be more based on how our body reacts to this infection and produces antibodies. And there are many types of antibodies, but the ones that we are currently looking for in COVID have been mostly IgG and IgM. Now, a lot of times people are confused about the forms of testing that exist because it is clearly, I think for an average lay person, this is probably the first time that they're doing something like this. So one is to actually look for the antigen, and by antigen, you mean the actual virus. So you're looking at either trying to find the RNA of the virus, or you're trying to find a protein that exists on the virus. And so those are the different kinds of testing. The most common type is the RT-PCR, which is the gold standard for testing. And over there, you're basically looking at a segment of the RNA for this particular genome, and you're trying to find out if that virus is present in the solution or not. And that's probably the most commonly used test that we see. There is also the LAMP test, which can be done in a more simpler settings. And then there are CRISPR-based methods to be able to find the virus as well. And then we are also seeing the emergence of antigen-based immunoassays that can be that will allow you to detect the virus in 5 minutes or less. But of course, there are always challenges with sensitivity of these kind of tests. And then there are some point of care devices, such as the one that we saw from Bosch and Abbott. Again, some of them do have their challenges with the sensitivity. And then the other types of tests that we find are the antibody tests, where you want to find out if the virus was ever present in the solution that you're looking for. And typically that is done either with a pinprick or it is done with the blood that you draw from a human body. The other way to actually look at it, and also many times in combination, are CT scans to be able to see how much the infection has spread. Now, when you look at genomics and you look at what are the genes that are involved, you see that it is in this diagram is which I got from another publication. You can see it has about 29,903 bases, and there are many different parts of this that you find that are involved in the genome. And there are many, if you look at this, you'll find that there are many different parts that are used in RT-PCR or any of the PCR-based tests for actually finding out if to detect that particular virus. But the ones that are most commonly used for confirming whether it is a COVID detection, I mean, if COVID is actually present, is the N gene and the RDRP, and also some parts of the ORF gene that we find are being used. So in an RT-PCR testing, you can usually do it with a nasal or a throat swab. And there are basically, primers and probes. And the probes also basically have a fluorescent dye and a quencher, which basically allows us to be able to see those or detect them. That's the way it is detected. But basically it is done with many cycles of heating and cooling. And that allows us to be able to amplify the virus if it is present and be able to then therefore detect it. So this is the basics of the RT-PCR. And while today most of it is being done by trained professionals, there is a possibility that in the future we will also start to see at-home sampling as well. And this is an example of about a total time where you would look at the infection. And I won't go through this in detail, but the approximate time that we are looking at is 28 days from the start of infection. So if somebody wants to find out, then typically it has to be done within this time frame as well. So let's move on to more, other than the fact that you can detect a particular, the virus, or you can find out if there will be antibodies that are produced in response to it. There are also many other aspects of genomics that are used in COVID. And one of them is in understanding our own immune system, because I think this time COVID has taught us that it is, given everything aside, I think a lot has to be said about our own immune system, our own lifestyle, and the comorbidities that we see along with it. So what are the areas that we find are valuable? One of them is to see whether there was susceptibility to the previous SARS virus that we saw earlier. And I think a lot of people have also heard about the cytokine storm, which is when our immune system goes into an overdrive and comes up to actually not fight off the disease, but also it ends up actually harming our own body. And then of course there are comorbidities like diabetes and hypertension and so on. And then you might have also heard that you also see that there are nutrient stores like zinc and vitamin C and others that are helpful in being able to combat disease. So what we basically did was that when you look at it from a genetic point of view, you find that these factors have an important role to play in the pathogenesis, and therefore we are able to now see the aspects, whether it is the ACE2 gene, whether the IL-1A or the IL-18 gene and so on. And we look at all of these reported in literature, but also we've been able to collect a lot of this information in-house and be able to come up with markers that will help us in understanding this. So what we did in April was to be able to come up with a report for all our customers to help them understand their risk and immunity to COVID-19. And so we looked at genes that were involved in cytokine production, regulation, and immune response, such as the TNF-alpha, the IL-10, and IL-16, and those that were linked with a cytokine storm or a severe immune reaction. As most of us also know that there are comorbidities that are also, that people who with these comorbidities typically have a much more severe reaction. And so we also look at conditions like cardiovascular disease, high blood pressure, type 2 diabetes, autoimmune conditions, as well as history of smoking that will enable us to see if they have a predisposition or not. Other than that, we also have seen that given that we don't currently have a real actual specific drug for COVID, one of the areas was to be able to look at a lot of other drugs that were being currently used. And so we looked at drugs like chloroquine, like abacavir, like other antiviral drugs as well. And you find that many of them do have a genetic component that is important for us to study when you're actually trying to see if that prescription is going to work for that particular individual, because for some, it might produce a toxic reaction, and for others, it might not be as effective. And similarly, I think you look at the nutrient stores like zinc and vitamin C and D, and see if you are predisposed to having a lower amount of that in your body and whether you need supplementation or not. Similarly, when you look at the sequencing of the viral genome, you can start to understand that there are two main things. One is to look at it from the host perspective, that is the human being that it infects. And the second is to also look at the genome of the virus itself to find out through sequencing if you can see if there was mutation as they infect people across India, or whether to start to see if there are different strains that have been coming and what sort of mutations have been there. So it can be used for, one, finding a good RT-PCR test to actually help us detect this. The second is to find out, where it originated and what mutations have occurred and how this is actually relating to the infection rates as well as severity. And similarly, I think you can do a GWAS study for Indian human samples who have tested positive to see if there's a trend or a marker that we can find. And it has also been used for drug targets and vaccine development as well. So the role of mutations, as we see, are very important. And so far, I think there have been large number of samples that are from the Indian genome also that have been submitted so that we can start to understand this better. And similarly, I think when you look at drugs for COVID, we find that there are many types of drugs, whether it's convalescent plasma, whether it's repurposing drugs, whether it's new drug targets. And in the new drug targets, we find that there are 29 proteins that are involved in the genome, and there are 4 structural proteins. And each of them is important to understand from a genetic angle, genomic angle, to be able to see how best to create that. And then, of course, there's traditional medicine. So when you're repurposing some of the drugs that are there, I think, like I mentioned earlier, it's very important to understand if for that particular individual, this drug is either going to be effective or it's going to be toxic. And similarly, I think when you look at new drug targets, it's important to be able to see, which of these, we've studied the spike protein, but there are also 28 other proteins, and whether those can be used to find new drug proteins or not. And similarly, I think when you look at vaccines, I think there are many types of vaccines that are there, but the newer type that we started to see now are examples would be the DNA and RNA protein especially, and that is also done using genomics. So these are just some examples, and I think with that I would like to, and we've been involved in genomics for 20 years. I had first started a company called Osimum Bio in 2000, and that ended up becoming one of the largest genomic services companies where we worked a lot with regulatory bodies like the US FDA and others, and we had offices in the US, in Europe and in India. And about 7 years ago, started Map My Genome, which is more on the consumer genomics as well as clinical genomics, and also very recently COVID testing as well, because we feel we are in a unique position to be able to use the aspects of genomics that we've learned over the years, but also to be able to combine that in this very unusual times to be able to find actual solutions that we can help the people of India, but also be able to advance science. So I think it's great that iDAC has created this summit, and we hope that this will, this new way of creating summit and information for people will help everybody advance a little bit of the knowledge. And hopefully, I think they'll get more people curious about this space and be able to take this further.
My name is Akansh Khurana. I am representing THB today. We'll over the next few minutes we will talk about technology advancements in healthcare. There's actually a bunch of action happening around the world. I think this whole pandemic has given a good thrust to the adoption of technology in healthcare. We are seeing this all around us. Uh, this initiative of kind of bringing the learnings from different companies, different executives together on this one panel in this summit is fantastic. I think all of us are looking to understand what's happening around us. I will do my bit of sharing some of the work that we do and how we can use clinical data and clinical evidence to shape up the treatments and shape up the patient outcomes. Uh, THB, THB is a healthcare analytics firm. A lot of our work is actually in the context of using data and technology in the healthcare, and therefore a lot of the next few slides are going to be talking about what's happening in this whole space of technology and data in healthcare. We all know that there's huge amount of buzz around the world right now. While on one hand we've been hearing about likes of Teladoc and Livongo mergers, the people call this the largest merger in the digital health world, uh, collectively valued at upwards of $38 billion. On the other hand, we are seeing a lot of action in our home market in India. We are seeing Amazon's news coming out of their entry in online pharmacy. We are seeing two of the biggest e-pharmacies coming together. Uh, we are seeing a huge amount of action around the globe. We are seeing, on one hand, likes of Teladoc and Livongo merger happening. All of us know this is one of the largest digital health deal in the world. It's upwards of $38 billion value deal. On the other hand, we are seeing a lot of action in our home markets, especially in the context of e-pharmacies. We've seen Reliance entering through NetMed's acquisition. Amazon's announced the news. Pharmacy and MedLife are emerging to become a unicorn. Collectively, we are seeing a lot of buzz right now on what's happening around the world. We've been, a report came out recently from one of the global research players, and we are seeing huge amount of investment uptake in the health tech world as well. As you can see, 6% quarter-on-quarter growth, $18 billion plus investment happened in the last quarter. Asia is actually seeing considerable share of these investments, specifically China. A large amount of money going into building large next set of healthcare companies. Today, they say there are upwards of 46 healthcare unicorns around the globe. So, all in all, huge amount of action, right? We're seeing mergers and acquisitions, we're seeing new entrants, we're seeing large amount of funding going into early stage companies, all in the right direction of creating the next big industry in the health tech context. The one thing that we particularly focus on, and one of the reasons why healthcare still continues to be underpenetrated, is because of the degree of underdiagnosis of diseases, undertreatment, lack of compliance and adherence, and in the broad context, very top down. If there are 100 patients in a particular disease indication, the numbers say that only about 20% end up getting regular compliant treatment, and therefore this huge amount of underpenetration right now. The outcomes as a result of that are poor, but also there's significant amount of growth that is still yet to be tapped. And this 80% underpenetration is where a lot of the focus is, where data can help solve the problems. This is where data evidence can actually considerably support the next phase of growth for the healthcare organizations. While this is an illustration, I'll give you some specific examples. Just pulled out some of the published literature. These are publications from across medical journals. As you can see, everything from dementia in India to diabetes in India, diabetes in UAE, in Middle East, in Indonesia, Southeast Asia, Malaysia. There's a large publication on osteoporosis across every country in Asia, on how it has been significantly underdiagnosed and undertreated. All in all, this whole problem of underpenetration across diseases, right? Everything from an acute to a geriatric to a pedia to to a diabetes style chronic condition. And this is what continues to lead to poorer outcomes and under-penetration of healthcare across the globe. We've at our end done some work in osteoporosis in India. This is one of the pieces of work that we had actively published and presented across conferences. One of the things that we learned was that post-menopause women, more than 45 years of age, only 1 in 500 women were getting diagnosed through a bone mineral density test. Now, what that happens is only 1 in 500 are getting diagnosed officially, formally, but the ones who do undergo a bone mineral density test, upwards of 65%, upwards of 2/3 of them are actually either osteoporotic or or have osteopenia. This is actually in itself an eye-opening insight, because only if, let's say, 100 more women were officially or formally getting diagnosed, we would at least be able to prevent fractures in 65 of those women, because we will find out who those women are who are at a risk of osteoporosis and osteopenia. This goes to show how the underdiagnosis is significantly low right now, and how just being able to improve diagnosis can considerably improve the treatment levels in the country, and eventually leading to reduced fractures, eventually leading to better patient outcomes. The good thing is the data is being created around the world right now, and data actually helps us generate the right evidence. How do we solve for this problem of underpenetration? How do we solve for this problem of underpenetration of diagnosis, treatment, compliance? It's actually one of the core pieces is using data-based evidence, and using data to produce real-world evidence research, using that to provide right awareness and education, making sure the access is available, providing the right decision support tools to doctors in form of diagnosis and treatment, and most importantly, continuing to run population health surveillance. Data-based evidence is going to become the next most important lever for us to drive structured penetration of healthcare and improve the diagnosis and the treatment rates across the emerging markets. The good news is that a lot of the healthcare data is now becoming available. Adoption of technology in forms of electronic medical record systems, hospital management systems, data lakes to be able to combine data from different sources, IoT devices, Fitbits of the world. There is just so much of data getting created. This is one of the available literatures that I pulled out from the internet. Clearly goes to show that the quantum jump of data availability in just a matter of 5 to 7 years is upwards of 20x, and that's the kind of exponential growth of data that we're seeing. That's the good part. However, what we still need to work on is how do we make sure that the adoption of use cases from this data are rampant as well. In the whole data maturity curve right now, most of the organizations that we see still continue to be on stage 1, stage 2, at best stage 3, which is aspiring for analytics, but really the use cases and applications are not core part of their strategies and execution. So while on one hand, a lot of the data is getting created, I think we need to now shift from just data availability to use cases and applications and making them integral part of our strategies and execution. And that is what the next most important piece is for us to solve for. I call this the use case factory. We need to be able to create series of use cases from this data set and be able to implement those use cases across the organizations. Next few slides, I'll talk about some of the use cases of improving diagnosis, use cases of improving treatment, use cases of improving compliance. On the first leg, how do we improve diagnosis using the new age tech and data? On one hand, the entire world is talking about telehealth right now. We spoke about the Teladoc and Livongo merger. But not only in the context of primary care, but also in the context of tele-ICU, also in the context of teleradiology. So in general, telehealth is one of the best newer themes that has emerged. It has been around for almost 2 decades now, but the adoption has suddenly gone up with the pandemic around. How do we drive access to patients in remote care? Uh, and how do we make sure that people who don't have access to healthcare today are able to get access to healthcare through the telehealth technologies? So on one hand, using technology to provide the access. On the other hand, patient awareness. Um, I took the osteoporosis example. In many cases, people actually don't even know. People, our parents, our grandparents at home, we don't even know that there is a way to prevent their fractures. Preventing fractures, the first element is educating them that this can be prevented. And therefore diagnosis is important, and therefore preventive care and going through a bone mineral density test is important. So providing the right awareness to improve the diagnosis. The third is real-time monitoring. With the whole IoT devices coming in, we are able to get timely alerts. We have continued glucose monitoring devices now. We have devices to predict on a real-time basis epilepsy alerts. These are all tools and techniques and technologies available now to be able to help diagnose a particular condition at the right time and act on it and provide the right intervention. And then finally, electronic medical records and electronic health records. Uh, there's a bunch of work happening now where doctors, while they are recording the patient symptoms and while they're recording the patient vitals and basic parameters, the systems are on their own able to alert doctors on the possible conditions, and therefore what should the doctor probe further. So on diagnosis, technology and data is being used in multiple ways. It is being used to improve the access. It is being used to improve the awareness. It is being used to do real-time monitoring through IoT devices and other medtech devices. And finally, electronic health records and softwares, which are able to provide nudges to the doctors to be able to improve the diagnosis of the patients. On treatment, there's a bunch of work happening on the treatment as well. We spoke about electronic health records. Not only are electronic health records recommending the right diagnosis, electronic health records are also providing the support to doctors in providing the right treatment. We have been talking about IBM Watson for a very long time. While there have been pros and cons, while there have been talks about how technology is helpful, the reality is the technologies today exist. The technologies exist to be able to provide the right precision support on treatment to the doctors. We spoke about patient awareness earlier. Patient awareness is one of the best topics I like because if you provide the right inputs to patients on the possible treatments and the possible side effects of treatments, it actually leads to best possible outcomes. If only you could make a patient asymmetrical information and just provide them the right information, they're able to act on it and able to get the right treatments for themselves. Device innovation, we have metered inhaler these days. We have devices to control pumps, to control insulin injection in a diabetes patient. We have so much of good innovation happening to provide the right treatment to the patient, just in the right dose, just in the right quantity. And then finally, evidence-based treatment. I love this topic. There's so much of work happening in providing clinical research on how one treatment is better than the other, health economics of treatments, what should payers end up subsidizing, where are the treatments more expensive but the outcomes are poorer. There's a bunch of work happening in using the data from our day-to-day practices and publishing literature and evidence on the treatment pathways. So as I said, on one hand, data and technology is being used to improve the diagnosis. On the other hand, data and technology is being used to improve the treatment in forms of softwares, electronic health records, in forms of devices again, in forms of patient awareness, and in forms of research. How is data and tech helping in improving compliance? The number one piece is a lot of the organizations are working on how do we work on auto refills? How do we work on trying to provide the treatment at the right time to the patient so that there is never a reason for not to take a treatment. We spoke about patient awareness, constant theme across the board, but making patient aware and educating the patient on side effects of leaving treatment midway, or when should treatment be actually reconsidered, or when should treatment actually be continuously taken. Awareness is a big topic. Again, providing right information to the right patient at the right time is the crux here. There are multiple pieces of work happening around creating interesting mobile apps, which always stay with you today. We look at our phone maybe hundreds of times in a day. So how do we use mobile apps to nudge the patients with the right information and the right coaching? And finally, smart care programs. A lot of the companies are care programs, which are long-term subscription programs, information available at the right time, access to doctor available in minutes, providing subsidies to be able to help patients get the right treatment, and provide subsidies to help patients get the right diagnosis. So there's a bunch of work happening on compliance, everything from automated refill to educating the customers to smart care programs to provide right incentives to the customers to take care of their health. So as I said, data and tech is being used to create a series of use cases today to be able to improve the diagnosis, to be able to improve the treatment, to be able to improve the compliance. All in all, collectively, as I said, working towards solving for this under-penetration of healthcare in the emerging markets and across the globe. Here is a case study. We spoke about osteoporosis earlier. We've done a bunch of work in osteoporosis. So here is the case study. As we saw earlier, only 1 in 500 postmenopausal women were getting monitored. Most of them, 2/3 of them, were actually found to be at risk of fractures. And a series of use cases came in handy to solve a problem like this, right? So we used a combination of 4 use cases. We used a combination of providing the right education to the doctor so that they're able to identify patients at risk and encourage them to do the diagnosis. We also did a large piece of work around making patients aware that fractures can be prevented. There was a bunch of work on publishing evidence and research on bone mineral density, on making sure this information is available to the medical fraternity so that they're able to see this for themselves. And finally, smart care programs. There was a large piece of work that we had done with a diagnostic chain where age is equal to discount. And how does it really incentivize customers, older customers who are at even higher risk of osteoporosis, to come in and get subsidized diagnosis and get identified if they're at a risk of a fracture. So using a combination of use cases, as I said, something on diagnosis, something about the right care program, something about providing the right research to the doctor, using combination of these. When we worked on these initiatives over a period of about 6 months, we saw that the diagnosis rate improved by 25%. Now 1 in 400 were getting monitored for bone mineral density, and there were clear doctor treatment actions provided. Now the next phase of this work is how do we actually convert diagnosis into reduced fractures? But that's the other piece of work, which is a continued journey that we have to travel on implementation of these use cases and delivering to better outcomes of patients at the end of the day. As we saw, there are a bunch of use cases of data and technology. There's a lot of work happening around the world to make sure that this under-penetration we are able to solve for this under-penetration. But that said, what will drive the change, right? It's not just data and tech. There are a multiple series of things that we need to be able to do to be able to drive this change. The first piece, we need to be able to adopt health tech to generate data. The data is getting generated. In many cases, quantum of this data is still getting generated in the developed markets, where insurers, where payers are encouraging and making sure that the data is available for them to be able to take the decisions. But how do we make sure that this whole data generation activity is seamless across markets? Markets like India, which are out of pocket, where doctors don't really have an incentive to generate the data. How do we make sure that technology is getting deployed to generate data? Government's taking a series of initiatives right now to create central health records. All of these are in the right spirit of generating as much data as possible. The second is, I think a lot of innovation is required. A lot of us need to collaborate to figure out ways to generate more applications of this data set and to be able to solve for everything from diagnosis to treatment to compliance and outcomes. Finally, we do need front runners to drive the adoption. It's easier said than done, but we do need organizations to become the front runners, lead the charge, be willing to make mistakes, but be willing to lead the change and the adoption of technology, data, and the health tech wave in the industry. So we need front runners, and finally, most importantly, we need to be able to publish as many case studies and examples so that others can benefit from this as well. So as I said, big problem, 80% under penetration. How do we solve for diagnosis, treatment, and compliance through a series of data and technology use cases? And these are some of the things we need to do alongside to make sure that the impact is actually big scale.
Hello everyone. We're talking about advancements in the hospital infrastructure via technology innovations. The number of technology innovations happening within healthcare are many. What I've done here today is slotted it into 3 blocks. Block number 1, which is our expertise significantly, construction intelligence. Block number 2, more to do with asset management or resource intelligence. And block number 3, which is accentuating medical technology. Mind you, it's something that I'm going to quickly cover so that you understand the breadth at which technology is getting used within healthcare. Within construction intelligence, we'll talk about project intelligence modeling, the benefits of it, its workflow, and its capabilities. Project information modeling is effectively tech-enabled construction management backed by engineering design and built environment sciences. So while we use a sophisticated technological backend, the base understanding of how things are built or engineered, that domain expertise is still very important. The simple benefits are time, cost, quality, of course. Time can be reduced significantly. We did a 6 lakh square feet hospital in 10 months from starting the foundations to the first patient being treated. There are several things that can be done to speed up the construction of healthcare projects, the need of the hour to have the infrastructure up and running quickly. Cost control. Hospitals are capital expenditure heavy. By fragmenting contracts, we could bring up to 25% reduction in capital cost of building the facility. And finally, increasing the productivity and predictability. The project information modeling workflow is divided into 4 steps. Step number 1, which is granularizing location and quantities. Step number 2 is scheduling activities. Now, what is different from the conventional method here is that by tracking a schedule by its resource application or its quantity takeoffs, the accuracy and the predictability of tracking is known to be increased greater than 80%. Step number 3 is a daily on-site workflow. There is no substitute, even when you talk about smart infrastructure, for self-consciousness. Most of the technologies are generating dashboards so that the team can come together. By mapping granularly every day what's happening at site, the extent of scheduled cash flow billing can automatically be generated. Step 4 ends with remote approvals. Getting expertise at multiple locations is going to be a problem. Remote working is increasing more and more. Via 3D scanners up to 1.5 mm accuracy, you can not only do the quantities, but do a quality check and cross-check the productivity that your resources have achieved at various activities. Along with transparency and accuracy, the capabilities that PIM provides is time and cost impacts, real-time quality, and sorry for the last slide, it's actually acute project control. Dry and modular technologies are increasingly going to be used, like steel structures, prefab buildings, toilet pods, dry walls. There are various such technologies that we would consider while starting off a project to ensure that speed can be achieved, time, cost, quality. That's the bottom line really. That's what happens with during construction. So you've got a context of while building, how can we build it faster and how technology can be used to enhance it. When you start operating the resource along with the various intelligent building management systems that are integrated within a facility, what is catching significant amount of pace is resource intelligence, which means intelligence of the people, the movable assets, the fixed assets, and the other kind of intelligence you can create. Of course, all this comes into one data lake, but what we are going to just talk about today is resource intelligence. Tracking of intelligence includes people, which are taggable and untaggable. Movable assets, which are not only high value, but think of a wheelchair. If the wheelchair wasn't there at the place it should be when it needs to get used, it's a bigger problem, though the value of the wheelchair is not very high. Inventory management. When you look at fixed assets, you're looking at wear and tear, building services, which is your intelligent building management system, and maintaining the branding around the hospital as well. What you're focusing on is anomalies and trends, mapped real time. You're tracking workflows, so things like OTUs, co-locating, whether the equipment, the people, the patient are there where they're supposed to be, facility management, simple things like anomaly alarms for nurse rounds, if the nurse did not visit a particular room as many times as she should have. Second is operations, which is your standard scheduling, locational, operational and maintenance, history of the asset maintenance. And finally, you've got patient-centric, which is turnaround time, engagement points, asset flow and density. The technologies that can be used to be able to bring about implementation is face recognition for untaggable assets. Some of the examples given there. Active Bluetooth for taggable assets. So sort of you can see the differentiation between taggable and untaggable. Active Bluetooth also for high value and critical to use equipment. Passive RFID can be used for inventory management, which starts from CSSV instruments as well, and of course goes up till the pharmacy and consumables. Passive RFIDs are very useful for mapping wear and tear of things such as furniture, lights, and doors. And finally, as we discuss, intelligent building management systems with CCTV and remote analytics. There's a lot of app enablement in terms of scheduling, diagnosis-based content that also can be integrated with a common data lake. So this is how resource intelligence can be implemented within a hospital with technology. Finally, we move on to what expertise medical tech or med tech brings on the table. Every hospital will have their own combinations to see what tech is useful for them. But the goals are set as training, workflows, medical equipment, and diagnosis. So under these macro headers, the basic considerations to start with is that medical equipment are already smart. Hence, there are many soft points that without using an additional layer of technology, you can find out information about the equipment. There are many companies that are doing breakthrough work with medtech. We've taken just a few examples here, 6 to be precise, of technologies that we've had exposure with and worked with for hospitals that we're consulting. In terms of AI for diagnosis to patient-centric AI, it's taking the whole gamut. The last slide for what can be done with healthcare infrastructure and in terms of how smart city principles of even activating the neighborhood can be accentuated. Means to activate as examples we've given, some I feel is very important or we feel are very important is preventive care network, satellite training centers, and whatever else you can do within the neighborhood. That's all from here. During construction, resource intelligence, and accentuating medtech. we ended with activating neighborhoods as a responsible healthcare asset. And that's what technology can do for healthcare as a snippet. Thank you very much.
Let us move on to our next session, which is a workshop on spectrums of technology in the healthcare sector, presented by Mr. Sandeep Kaul, CEO, Hipla Technologies.
Hi, good afternoon, everyone. Thanks for giving me an opportunity to present our company, HIPLA, and especially talk about the importance of digitization slash technology in healthcare. It's very important for us to realize that healthcare is a key pillar for our daily existence. We have seen what has happened with COVID. We have seen how our healthcare systems have been heavily taxed. I truly salute the efforts of doctors, frontline workers who have really managed to get us through. But again, that still brings us to the key question of A, is our healthcare enough? B, what can be done to enhance its reach? C, how can we use our existing resources and make healthcare affordable to everyone? So this is primarily where HIPLA steps in. We have seen, I don't have to spend too much time on, the worldwide established matrices by WHO on the quantity of healthcare workers and what's available in India. But what we are trying to do at HIPLA is to extend the reach of technology to reduce the stress on healthcare, and that's why I'm going to go ahead and explain our solution in detail. These are some of the key requirements of what how healthcare needs to be protected, enhanced digitally for COVID prevention. These include things from smart access to maintaining social distance, bringing technologies for respiratory hygiene management. How can we actually use automated solutions for contact tracing? We know that right now contact tracing is very manual and very laborious. How do we actually, use disinfectants? How do we really monitor whether PPPs are being used? Right from separating different zones in the hospitals and isolation of staff. So everything around here needs technology, and that's where HIPLA comes in. And so what we do, 1 minute, yeah. So our solution, we are a company which helps healthcare healthcare facilities such as hospitals, clinics, including clinics and workplaces, to bring elements of a solution towards COVID prevention, such as maintaining social distancing, contact tracing, and that's where one of our solution, computer vision, helps a lot. Let me explain where we come in versus what we are looking and proposing. So problem A is, there's a lot of manual tracking of social distances. These days, we are actually trying to make these little boxes, asking people to step in. Every time a visitor visits a facility, we are actually manually processing them. Contact histories are not fully automated. In addition to this, patient history is not available, very easily. Although we have seen Prime Minister's announcement on Healthcare ID, which we really welcome because it's going to accelerate digitization of healthcare, what we still see is a problem in terms of adoption of technology across healthcare, and we really feel that there are many places where we can actually go ahead and improve this. So how does our technology help is we basically divide our solution into 4 different pillars. It's about we bring video analytics, and what we do is we use existing CCTV feeds of hospitals and healthcare assets and run advanced level analytics on top of it to produce very intelligent insights. These can be right from identifying patients, identifying hotspots, ensuring that safe distance is maintained. If safe distance is not maintained, we can give alarms to admin. We have smart access systems. These are touchless entry. systems. We can build rule-based engines on, who can access a healthcare facility, who cannot, and everything can happen in a touchless manner. We have wearable sensors, which monitor the different vital stats of patients, and of course, we complement everything around a mobile application which can help us to communicate directly with the patient. Talking a little bit more about our hardware solution, which is Smart Access, is contactless checking. What we do going forward is we actually dispense or we give access cards. These cards can help people access different kind of areas inside a hospital. Again, wearable sensors can help us for social distancing nudges. We can actually help people structure things, their movements around it. In terms of video analytics, we can help to separate different zones. We can build intelligent matrices or zones where we can allow um, people to have access to a particular zone versus not have access to another zone. Say, for example, the healthcare facility puts up a zone, for COVID patients, then we can actually build matrices to ensure that rules to ensure that no one else can access these. Going forward, to again complete, this presentation, the market USPs we bring is AI-enabled video identification, customized notification to stakeholders. I already spoke about hotspot identifications. The most important element being that there's no human dependency. Technology can really do quite a lot of stuff, and everything can be customized according to a flow. Let me know. We have, just to sum up my presentation, we have gone ahead and spoken to a lot of healthcare professionals, and these are some of the things which we have heard from them. Like manual contact tracing, is really set up for failure. It's not possible to actually, do manual contact tracing, and not having an end-to-end solution for patients, visitors to access a healthcare facility is a problem in calling. And, this is where again, people can come and help provide technology solutions to this. This is basically my presentation, and I'll be happy to answer any questions. Thank you.
I would like to thank Mr. Sandeep Kaul for sharing his views about the industry. Moving on, we have our last and final segment where we speak about future of telemedicine. Our moderator for this session is Ms. Soumya Srinath, Director, Transformational Health Practice, Frost & Sullivan. We also have Dr. Rishi Mohan Bhatnagar, President, Aries Communications, Chairman, IET Future Tech Panel, Chairman, IoT AI Committee, Broadband India Forum. We also have Professor Krishnan Ganapathy, Director, Apollo Telehealth Services and Apollo Telemedicine Networking Foundation. I would now request Ms. Srinath to take the lead.
Hello, everybody. Thanks for joining today's summit. And we are here today to speak about telemedicine, which is one of the hottest buzzwords in the industry, especially during the COVID times and across the world. So we are here today to see what is telehealth and telemedicine in India and what's the road ahead. So that's what we are going to discuss today. I'm Soumya Rajagopalan Srinath. I'm the Director for Consulting with Frost & Sullivan's Healthcare Practice. I head the healthcare practice for South Asia business, and I've been with Frost & Sullivan for the last 15 years and worked across the medtech sector, healthcare globally. And I'm currently based out of Singapore, and I would love to contribute to this conversation today on telehealth. I would also like my other panelists to introduce themselves. Over to you, Dr. Rishi.
Thank you, Soumya, and thank you for inviting me for this conference. It's a pleasure to speak on this very important topic in today's world. My name is Dr. Rishi Mohan Bhatnagar. I am the president of a company called Aries Communication. Aries Communication is a US-based Silicon Valley technology company we have been since last 2 decades, we are working on Internet of Things. Since 2016, we started in India, and during my presentation, I can tell a bit more. Currently, I am the member of the NABH committee working on e-health standards. Okay, I am the chairperson for the Future Tech panel for IET, which is a 150-year-old institution, and working in quite a number of other areas to see how Internet of Things or digital technologies can flourish and grow in our country. Thank you.
Great. Great. Mr. Ganapati, can you introduce?
Good afternoon. My name is Ganapati. I head the telehealth division for the Apollo Group of Hospitals. I'm a neurosurgeon basically. 45 years I've been doing neurosurgery and the last 20 years telemedicine. I'm a past president of the Neurological Society of India and the Telemedicine Society of India. I'm also a digital health expert of the World Health Organization. And I have been given 420 seconds in which I've been asked to talk about what I think is going to be the future of telemedicine. And having been in telemedicine for the last 21 years, I'm going to put you on a time machine and take you with me on a journey which I'm absolutely sure is going to happen in the next couple of years.
Thank you so much, Mr. Ganapati. It's actually nice to be on the same panel like eminent personalities like yourself and Dr. Rishi. I'm looking forward to speak to you and share my initial views. So I'm going to straight away look into my presentation. Before we go ahead, we are looking at future of telehealth market in India and what's going to happen. But this telehealth, telemedicine, virtual care. So I wanted to hear your views, having been in the system and seen the transition in this entire space. So what is telehealth and telemedicine according to your views, Mr. Ganapati?
Well, as I told you, I started telemedicine in 1999, and the growth in the last 5 years, the first 15 years I spent just in creating an awareness and evangelization. The last 5 years, there has been an incremental growth, maybe about 10% compounded annual growth rate for the Apollo Hospital Group is concerned, mainly because of public-private partnerships. Several state governments decided on using telehealth. We call it remote healthcare. I think that's a better word than telemedicine. Personally, I don't like the word telemedicine, and I'm very happy you're using the word telehealth. Telehealth is much more encompassive than telemedicine, which denotes a single doctor-patient relationship. A strand of RNA, I would like to call him the Chief Global Transformation Officer, if you like to call it, a strand of RNA, the COVID-19 virus, we all know in the last 6 months has totally changed the very concept of remote healthcare. And if you had asked me 1 year ago, I would have I would not have been that optimistic, or I said, we'll keep trying. But the last 6 months have shown beyond doubt that even after the pandemic is denotified, and even if at all things settle down in a different way, telehealth is going to be a part and parcel. I no longer will have to spend my time trying to persuade people, trying to popularize telemedicine. As a clinician, now I think it is Soumya and other people who need to develop business models, who need to go into the operational details, etc. My job is over as a clinician, telling them what telemedicine can do. Today, thanks to the virus, everybody know about it. So now it's entirely the other group of people to make it functional, operationally effective. At the end of the day, I use a word which for the last 20 years I've been using called YFM, W-I-I-F-M. What is in it for me? So I think this is the most important point to address. All the stakeholders in the ecosystem, the connectivity, people providing connectivity, people providing software, hardware, etc., all of them get paid upfront. But even today, there is no real model for a medical doctor to be compensated for his time. Of course, now with digital marketing and digital payment, all this will become history. So I think the single most important problem which you people, the next generation, should address is to make this, incentivize everybody, carrot and a stick, make everybody understand that it is in their interest to avoid physical visits to a hospital as far as possible.
Great. I'm so happy to hear this from you, because I hate the word telemedicine too. Not that I demean it. It is just that it does not cover whatever telehealth and virtual care and remote care provides holistically. So I'm happy to hear that from you, because you have been in the system for more than 3 decades to understand what telemedicine and telehealth is. So, Dr. Rishi, your comments on how you see this entire journey now.
So I fully agree with Mr. Ganpati, and thank you very much, sir. You are of our generation. It's not that you are. We are in the same generation. We have to learn from you. So Soumya, we are doing IoT since last so many years, and on an pan-India level, if I see, the logistic, transportation, utility business, utility were really looking after and doing digital and tele uh, IoT implementations. But healthcare, and to be honest, more because of the regulation, okay, regulatory requirements, everybody knew that for a country of 1.3 billion with so many infrastructure issues related to number of doctors available per patients, number of hospitals available, number of in today's pandemic time, we found that the ventilators were so less. Okay, with all kind of issues, we all were aware there is a need for a technology to be used, and there is no other way we can do it. Okay, with all that knowledge, the regulation and the culture, sometimes, as sir said, doctors are paid when a patient comes and visit them. Okay, so how the financial or the business model will work. And the second thing is, you always like to visit a doctor, and
Correct.
if somebody touches you, you feel more confident and comfortable. That's a culture. So one is the business model, second was the culture, and the third was the regulations. The regulations were not helping the telemedicine or telehealth. It was more restricting it. The national health policy that came in 2018, that was trying to see how can we grow this telehealth and many other things. But the legal framework need to be changed, and that was what is happening now after the pandemic. And with the kind of standards, guidelines people are working on, I'm expecting that there will be a huge growth in telehealth. Suddenly, because of the pandemic, the implementation of, I'm not using the word technology. Healthcare has always been far ahead in using technology, but using telehealth or remote patient monitoring was something which was not at a level where the need was. And after the pandemic, the expectation is, and now people have seen that you can't live without it. And so it has to grow. It is growing.
Great. Okay. So now I want to share our views on how we look at telehealth overall. So we call it the virtual care ecosystem. What Dr. Ganapati spoke about remote care. We're just using the word virtual care. It is the same thing, but using the word virtual that is probably commercially much more meaningful in terms of buzzword. Now we look at this entire virtual care ecosystem as virtual visits, mHealth, wearables, remote monitoring. And when we look at this holistic approach, they're all still some form of care. But like what you mentioned, Dr. Rishi, tying them all up is the practice management solutions. How do you build? How do you schedule? How do you avoid errors? How do you actually share data? How do you make it if I can say foolproof, and not just use this entire platform as charity? So how do you monetize on that? So that is the holistic aspect of virtual care ecosystem. You just can't have a virtual visit platform, a video conferencing solution, mHealth app, or a wearable and a remote monitoring tool or device just to cater to the patient. It is going to be a lot more than that. And the things that connect all of this together and make it viable, meaningful is what we are looking at as the virtual care ecosystem. And we look at different tangents and different grades of adoption. This is again globally. Telehealth has been, has been part of most of the established market, but not in a significant way as it is today. And globally, 2,000% increase in from March to April in terms of virtual visits in the US alone. That's the kind of increase that we saw in virtual visits, and the pandemic kind of threw across the EHR, EMR utilization, claims management, etc. much better. So we are looking at different tangents of availability and adoption scale of different product lines. The greens are the ones that will have easy adoption immediately, higher need of adoption. The blues are one that is going to be the next stage or next phase of the adoption. And the oranges are the ones that will take longer time to adopt, but it is still an integral part of the entire ecosystem to be successful. That's our views of the market. But I would again now go out to Dr. Ganapati to understand. So where do you think in India is the awareness beyond the urban care for telemedicine. How do you think today people leverage telemedicine or telehealth? I don't want to use the word telemedicine in this discussion, but telehealth today beyond the urban societies. Do you think the penetration is increased?
Yes, the penetration has considerably increased, and tier 2, tier 3. See, let's not talk about the villages. We need to, it's sexy, so to say, to talk about providing healthcare to the remotest villages of India. I don't think it's a crime to provide a telemedicine, telehealth to tier 2, tier 3, even in the metros and the state capitals, etc. That is one thing. The second thing is the connectivity is steadily increasing, and I've seen it grow in the last 15, 20 years. And I'm absolutely sure that in the next 3 years, at least 50% of India's 640,000 villages will be covered. It's going at an amazing speed. And the Indian government has announced that 5G is going to become operational in 2 to 3 years, at least in the big cities. Now, the presence of 5G is going to totally change the way in which we are looking at telemedicine so far as tertiary hospitals are concerned. A very important development in the last couple of months you would have noticed is IDRAI, the Insurance Development Regulatory Authority of India. They have formally asked health insurance companies to recognize teleconsultation for reimbursement. I think this is going to play a phenomenal job in the months to come. So these are all very new developments. The third thing is political will. See, the absence of a political will, a few passionate people, a few mad people, there is no way they can introduce telemedicine for 1/6 of the world. Today, the Prime Minister of India, in every single address to the nation, he has mentioned repeatedly using the word telemedicine, telemedicine. Niti Aayog has a full, very senior officer in charge of telemedicine. All state governments now have a nodal officer for telemedicine. The 450 medical colleges in India have been directed to have an officer exclusively in charge of telemedicine. In fact, last week, one of my junior colleagues told me how they conducted a DM neurology examination totally virtually at the All India Institute of Medical Science. So this is what is happening in the real world. So I'm absolutely certain that I'm not at all pessimistic. I'm not even realistic. I'm optimistic that virtual healthcare is going to be the new norm.
Lovely, and so glad to hear that, because we also agree that the regulatory aspects that was actually, if I can say, reducing the pace of the scalability has now been addressed. And like you mentioned, iDAC coming in to support telemedicine will change the way this will be looked into, because out of patient care has actually denied access to care for multiple, out of pocket expenditure has denied access to outpatient care for crores of patients and crores of visits. So with teleconsultations being reimbursed, we definitely think that will change the way this entire aspects of care will be there, and the diagnosis will be better, early diagnosis will happen, treatment regime will be better. Overall, we believe the health index of the country is likely to only improve, and this is why we believe, where we think it is important to capture the entire aspects of health and where support is required. So if you see the blues, we believe that the health of the states largely is suffering much more in non-communicable diseases than the reds and the pale peaches. So we think these places require umpteen number of supports, and they have the largest buckets of tier 2 and tier 3 cities. So we definitely think telemedicine is the best way to reach to this patient, and access to quality care will improve. So we see this growing significantly and making an impact. But I would love to hear from you, Dr. Rishi, as to how you think technology and if I can say solution implementation is going to be better or made easy in the future because of all the visits that is happening currently.
So Soumya, in my presentation, I have a slide on it. Okay, but I'll like to share here because
I'm going to then remove my slide, and you can probably check that. Yeah,
that will be really nice.
Yeah, please.
Are you able to see this?
Yes, we can. You might want to go on full screen mode. On the top right hand side.
Yeah. Is it okay?
Yes, it is.
Yeah. So basically, there were 155,000 village gram panchayats where there was a mother and child care centers. Okay. And there used to be, a lady called Asha Didi who used to
Yes.
go with the polio drops and the pregnant women and the newly born babies. That was their scope of work. That means there was a room that was set up. There was a training that was given to a lady, okay, who was supposed to do it.
Correct.
But what was missing was the BharatNet digital infrastructure for connectivity. In the last 5 years, 150,000 gram panchayats got broadband connectivity. Okay. The optical fiber broadband connectivity came to 150,000 gram panchayats. Okay. That was the BharatNet project. These village they call it Mother and Child Welfare Center, Jacha Bachcha Kendra. They are now being upgraded into the primary health center. These Asha Didis, as part of the Skill India mission, were trained in addition to the other young boys and girls in the village to get into a area where they can start monitoring with devices. Okay, so it's no more only a pregnant woman and a newborn child, but how can they become upgrade to a clinic? So there was a huge program that was coming where the current infrastructure to be upgraded, the network to be reaching the village, the devices to be identified, the devices standards to be checked, the testing of these devices, the cost of these devices, everything needs to be done. Now the whole data coming, and there's where the records to be maintained and all. This whole structure is now in shape in many of the villages. Okay, you won't believe the last mile. Many of these people used to come to the city just to get some tests done, and the huge productivity loss. Now, majority of the things can be done here, and in these villages where the pilots happened, 70% of the people are stopped. I shouldn't call stopped, but they were told there is no need for you to come. Okay, yeah. So there has been a huge reduction from these gram panchayat areas. So people are coming there, and this is also creating jobs. So it's a complete model that has been created, and these device companies, all these people have been able to ask for standards. I personally was part of the device standard committee of Government of India, Ministry of Health and Family Welfare, and now with all of these things coming, okay, and as sir also said about IRDAI coming out with the remote, considering them to be consultants to be paid in the remote patient monitoring kind of thing. My expectation is very, very optimistic. Things are moving in the right direction. Things are happening on ground and not only on paper. Okay.
Correct.
And that's a very big difference between how you think implementation will happen for a country of our size and our diversity and the ratio of doctors per patient in both urban and rural areas. We can't live without these things. Okay.
Correct.
The recent announcement on 15th August by our Honorable Prime Minister on the National Health Mission and starting that, inaugurating them with everybody in India, like Aadhaar card, will also have a health card or health ID.
Digital health ID.
Digital health ID. That's a very huge step. And the kind of infrastructure and everything, the usage of technology has been at a peak with this particular government, is what my thought is. People will definitely get a lot of benefit. These telehealth and telemedicine is currently getting implemented in many parts. And, I'm very hopeful that things will improve further.
Great. Dr. Ganapati, I wanted to check with you. So, with the government initiatives taking care of the rural aspect and, private sector also trying to invest heavily into the tier 2, tier 3 cities, do you think that, access to care will not be a drawback in the country, and health and diagnosis, early diagnosis and mortality rates should see a sea change and decline significantly, in this decade?
Well, decline significantly, I don't know about that. We have to understand that there's a lot of difference between the real world and the utopian world. Certainly, it will start coming down. There's no question about it. But one main thing is the point of care is going to shift. It has already started shifting the last 5 years ago. When I was a medical student and a postgraduate in the last century, a doctor used to take the blood pressure. Okay. After that, today, we are all familiar with glucose monitoring, blood sugar monitoring. You check your own BP, etc. Today, already it started happening. We are converting houses, we are converting rooms into step-down ICUs or middle care level of ICUs. So the point of care is going to shift. I foresee that brick and mortar hospitals are no longer going to be there 10 years from now. Hospitals will only be for surgical procedures, for trauma and things like that. Investigations will also be done. Laboratories, a doctor in your pocket, a hospital in your pocket. These are the phrases which so long were being used as phrases, but this is going to become a reality. So the point of care, like Walmart has got kiosks. We already have started, Apollo Hospitals have started. So there are going to be health kiosks in every floor in a multi-story building. Of course, now work from home. So everything is going to dramatically change. The most important thing is the footfalls, physical footfalls to a hospital is going to come down, mainly because of digital payment. Hospitals will not lose revenue. Until now, actually, the CEOs of most hospitals didn't like me, because if telemedicine really succeeds, I would be reducing the footfalls to the hospital and so many associated expenditure. As business people, you all know when somebody comes to a hospital, there are so many other things he spends in, right from a CT scan to an ultrasound. As a teleconsultant, I just want the investigation. So the investigations get done somewhere else, etc. There is a conflict of interest if you want to look at it that way. But now all that is going to change completely. All that is going to change completely. So I think this is the point of care is going to shift.
Lovely to hear that from you, because I strongly believe, and I always say, hospital is not the sanctorum of healthcare system or healthcare delivery. It should not be the case. It should be the last resort. And if patient, the point is to take care of the health. So keep the patient healthy for the longest time, or keep the population healthy for the longest time, is the, if I can say, phrase for most governments and health systems. And to do that, like you mentioned, lab on chip, lab on pocket, doctor on pocket, 24/7, real time, support, real world evidence, AI, analytics, all of this with the types of technologies and sensors, personalized medicine practice, practice at, anywhere and everywhere, etc., is going to be the future. With all of this, do you think globalization will happen? Do you think sitting in, a remote location in, Pune, a doctor can also cater to somebody in Bangladesh, somebody in Pakistan, somebody in the Middle East? Do you think that will also happen?
Technically, it is possible, but culturally, there are so much differences. It's not going to happen easily. Number two, the United States, only because of the pandemic, they relax certain registration rules. You know that in the US, prior to the pandemic, a doctor practicing in Chicago cannot practice in New York, cannot even practice in the state which is bordering Chicago. So when that is the situation, there is no way that I will be allowed a doctor in India, whatever be my background and credentials, there's no way I will be allowed to give a prescription or see a patient in Bangladesh. So what is required is, but I foresee that the World Health Organization, the United Nations, I foresee that in the next 10 years, we will have an international licensure. Europe already has an international licensure. The European Union has got a separate scheme whereby any doctor in Europe is legally entitled to examine a patient and give a prescription to a person who in any country belonging to the European Union, but then is confined to the EU. Similarly, this needs to happen. So I really don't think in practice it's going to become in a big way. But having said that, Government of India started the Pan-African E-Network project 12 years ago. I was very actively involved in that. And from my department, we were connected to 48 different countries in Africa. But that was a government-to-government project. So the Ministry of External Affairs, Apollo Hospitals was used as an intermediary for the technical part of it. So government to government, yes, it will happen, but I don't think it will happen outside a government to government scenario.
Got it, understandable. And in all of this, right, there are different types of players. Like, hospitals like Apollo have their own telemedicine platform. And there are the standalone, companies that are offering telemedicine services, and companies that just offer the telemedicine platform for doctors and hospitals to purchase and use them. We call them the aggregators. So there are different types of players. So who do you think is going to succeed in this holistic scheme in probably in the next 2-3 years' time?
telemedicine will not succeed unless every single player succeeds. So I don't like to answer your question. I don't wish to have Apollo succeed. I don't wish to have A, B, C, D, E or F succeed. Dr. Pratap Reddy told me 20 years ago, it's so vivid in my memory, when I went to ask him if I could set up a telemedicine unit in another competitor hospital. He said, Dr. Ganapathy, your job is to make the pie bigger. Once you make the pie bigger, your share of the pie will automatically increase. So I think in a country of the size of India, there is enough and more than enough. And health is one industry which is recession proof. I can live without cars, I can live without an air conditioner, I can live without entertainment. But unfortunately, I cannot live without health care. So the answer to your question, Soumya, is that I foresee that there you can split the pie. I mean, there is so much. Competition is required. Yes, agreed. But it should not be a monopoly, cannot be a monopoly. The day when it becomes a monopoly, there will be no progress.
Great, and I'm so happy to hear that, because that is our views of the market as well. In the US and Europe, there is so much of it is a highly it's not a competitive market; it's monopoly over there. But in India, we see it's a fragmented market. There is no one or two players who's actually taking a bigger pie of the entire share of telehealth. There is different players catering to different types of audiences in different states and making their own difference in benchmarking, and which is the way it is currently, unless consolidation through mergers and acquisitions happened. And with the current trend with e-pharmacy starting up, I won't be surprised in the next 3 years telehealth consolidation or telehealth platform acquisitions become a norm. I don't want to predict anything, but I just want to say that at least currently we don't see a change in terms of market shift. But 3 years time, unless acquisitions happen, it will still be a highly competitive market with place for everyone who is interested in this entire gamut of virtual care ecosystem to play and also succeed in the country. So with that, I kind of wanted to ask you, Dr. Rishi, do you believe in collaborations with other players, or what do you think about the marketplace business model? Because you have a certain aspect, somebody else has other aspects that go into the telemedicine, but telemedicine entire ecosystem. So what do you think about collaborating or route to market for the business model aspect?
So I fully agree with Dr. Ganapathy that this whole market needs to grow together. So whether it's a care provider, caretaker, intermediaries, insurance, pharma, all those people needs to have that business model. So people like as he said, we need to work on the business model where everybody can earn, everybody has something to work on, and the whole system has to work. It is not possible that only one part can work. And as he very rightly said, the opportunity size is too high. Okay, so the demand is so high that everybody can live together in this particular market. So while the competition will be there and people will be happy going into a particular hospital in Delhi than the other, that will happen. So is the insurance, so is the pharma, so is the other equipment. But the market is huge. Everybody has to work together. I just want to add to your previous point on the remote patient monitoring happening between different countries. Okay. Sometimes, Soumya, we are not, and I totally agree with Dr. Ganapathy that the government-to-government thing are happening when we are going to Africa and all. The data protection, the privacy, the security, okay, all these things are still not defined. Okay, forget about India level. It is not even defined at India level. Okay, so we are still waiting for a Data Protection Act. We are still waiting for a standard and guidelines for e-health. Okay, while the government has been really proactive and working towards digital health mission, but we do not have a data policy. We do not have a privacy requirements. So while we are and standards for telehealth. Okay, so when we don't have it only for our own country. Okay. Thinking about between America and India and Europe and India is the next step where the WHO or the World Health or United Nations needs to work and participate. But I have been really while I am a technologist, so I have been really advocating towards the legal framework and policies, which will help and start helping and growing it. Okay, a lot of things have happened, but still number of things still are awaited to happen to take it to the next level. Because the sooner we start implementing, people will talk about their privacy, people will talk about data. We still don't have an answer for interoperability. Okay.
True.
You know, today my data cannot go out of a hospital, and we are looking about digital health. Okay. So, you know, the data privacy and all those things needs to work. Otherwise, the things are going in the right direction, and I'm quite hopeful that um, you know, the way things have started growing in the last few months because of pandemic, my expectation is that it won't be at another decade. It should be faster than that, that we will be in a position to see results and of telemedicine implemented in our country.
Great. Okay, I think we kind of wrapped up the 30 minutes slot. Is Dwanika there? Dwanika, should we wrap up?
Yes, I'm here. I'm here. So we've almost, yes, you're right. We've completed the half an hour slot. And what I would request each one of y'all to do is y'all can just give a closing note from your end on the topic and from your own side, basically, that, you want to close this on such a note or something like that, basically, like a closing note from each one of your ends on the
Sure.
topic.
Okay, so Dr. Ganapati, would you want to go first?
Okay. See, I like the phrase team. Together, everyone achieves more. There is no I in team. So whether you like it or not, the medical doctor of the next decade is only a member. He may be the first among equals, but he certainly cannot work at the way when we were trained, when we qualified. There was no such thing as a hospital administrator. There was no such thing as healthcare information technology, etc., etc. So I think it is very essential that all the people in the healthcare ecosystem understand the importance of the other person, starting from the surgeon, starting from everybody. I cannot do my work properly without Ernst & Young and McKinsey and all the big companies. Similarly, the MIOT, your IMOT, Dr. Rishi, he may be a brilliant technologist. He knows inside out of artificial intelligence and machine learning, but he does require my inputs as to what is really relevant in a clinical setting. The only thing I am concerned about is that I have a feeling that technologists today develop a solution and then go in search of a problem. I don't think that is correct. The clinician should come to the technologist and say, look, this is my problem. Can you help me? Now it's the other way about. The technologists decide on what clinicians should do. So this is something I'm concerned about. Otherwise, I think we are moving in the right direction.
Great to have your comments, Dr. Ganapati. Dr. Rishi?
Yeah, thank you, Soumya. And as it's been a learning with Dr. Ganapati, with such a senior person on a panel. You learn. The technology, as a technologist, we can't work in the healthcare without them. And, we do not understand what they are currently, how to learn and create a, technology which can help them. So the subject matter expertise is something which is always required. So I fully agree with him. My, the last comment in this particular session is that I'm very, very optimistic about telehealth to be growing in India. Okay. We as an organization have been providing connectivity and doing digital solutions in the United States, in Australia, in Europe. But the pace of healthcare utilizing the remote patient was not too fast in our country. I'm hopeful that with the pandemic, this will grow and we will be in a position to get it much faster. And that's going to help the masses in our country, which is going to be a much bigger shift overall. That's all from my side. Thank you, Soumya.
Thank you, Dr. Rishi. So after having heard, both of you speak in this entire discussion, and I'm so glad to have been, one of the panelists along with you both, and, contributing so much to society. So I want to reiterate the fact that, having been in this healthcare sector and tracking it for the last 15 years and understood how things have happened globally, I wouldn't have expected telemedicine to be a big market in India before COVID. Like what Dr. Ganapati mentioned, I wouldn't have thought India is ready for digitalization as yet, would have been my comment probably last August. But today with COVID coming up, I strongly understand and, in fact, appreciate the possibilities on earth. And today, all Indians together can actually transform and quicken, accelerate the digitalization process. And the government, like what both of you mentioned, ably supporting it, it is going to become a reality. In the global world, we call the Star Trek tricorder. That is the next requirement in the ecosystem, because according to Star Trek tricorder, that is one device that can do everything for a single patient, from testing to diagnosis to treatment, therapy, monitoring. It can do all. So that's the kind of device that the world is looking at. And I wouldn't be surprised by the end of the decade, we may not have a Star Trek tricorder made available, but we might have something equally important that is available with the patient's hand. Because like what Dr. Ganapati mentioned, the team that is going to support is going to be supported first with the patient's requirement. So the patient is going to be well aware of what are the conditions or the systems or dysfunctionalities that he's suffering from, and going to the doctor to validate it and using the technology to manage it better. So we definitely see the entire team of systems and doctors and patients working together to make the healthiness quotient of the country much better. So thanks for your time today, and looking forward to speak to you soon in another panel.
Thank you, Soumya. Thank you, Dr.
Thank
Rishi.
you.
Thank you. Thank you, sir.
Namaskar, good evening, ladies and gentlemen, doctors and members of the healthcare fraternity. We've had 2 days of extremely exciting presentations, discussions, ideas on healthcare and infrastructure. It's been a fabulous 2 days with extremely eminent speakers and personalities in their own fields, and they've come up with some fabulous ideas, with some fantastic suggestions for us to take forward and implement. I hope you all have enjoyed it, enjoyed the 2 days. I hope you all have taken with you certain pointers or certain action points that can be implemented in the future. From my end, I've learned a lot, and I've enjoyed this entire 2 days a lot and gained an immense amount of knowledge. I would like to thank all the speakers, all the participants, all the audience who have been a part of this 2 day healthcare and infrastructure summit. Thank you all very much. Namaskar and wish you all the best. Thank you.